I've got a question about subarachnoid. So I had a shift the other night, and we had a patient, worst headache of life. This was over at the Fort. And so the attending I was with directed me to like a talk from David Newman on Smart EM about not doing an LP after a CT as long as it's under 6 hours. So I just want to know what you guys thought about that.
Dr. Reed really likes that question. So not doing an LP at the so the question is, should we be doing an LP in that patient who presents with the worst headache of their life if they present within 6 hours to your emergency department?
Got it. Want to start that?
Sure. So I think the big thing for me is it depends on what the patient wants. The classic teaching of, yes, if I'm going to do a CT scan on you, then I need to do an LP because CT scans do indeed miss folks. And depending on the study you read, that miss rate is about 1 in 300 or so. And the fact that if you miss it, they have about a 50% chance of dying because you missed it, it's a number needed to kill of about 1 to 600 to 1 to 700 if you go by a pure CT only for this kind of person, okay? Now, some people are terrified of LPs, and they understand that risk, and you can say, look, there are a very small number of these that we miss, and I would rather do an LP. And so I think that it is a little bit early, perhaps, to say, I'm going to do a CT scan, not see blood, and not even talk to the patient about an LP. Okay, I think that's too early for me. In practice, when I talk to people and say, look, we miss 1 in several hundred of these, there's nothing wrong with you coming back, but you could get sicker because we could miss something with what you're telling me. Do you want me to do this or not? It's really kind of their preference of, are they willing to go through a uncomfortable but shouldn't be very painful procedure and hang out in the ER for a couple extra hours. And that's up to them. If they look sick, I don't even offer. I just basically say, we really need to do an LP because I'm actually strongly suspicious and I'm surprised that we didn't see any blood. But if the kind of tough person that you're not really sure of, I just talk to the patient and let them own the decision.
I think you also have to understand where that recommendation comes from, okay? So that recommendation comes from studies done with neuroradiologists on call, all right, who are experts at reading that study. That's not always the case, so that's a big limitation, all right, if they present within that 6 hour window. Other thing too, remember, acute hemorrhage doesn't show up as well in that anemic patient too, so if they have a history of anemia, maybe want to bear that in mind as well. So otherwise, if they're within 6 hours, exactly like what Dan said, if they're within 6 hours, it's a shared decision for me. You know, studies seem to show 1 in 600, the right patient, 1 in 600, 1 in 700 will be missed. So if they want it, we'll proceed, and you know, it's not unreasonable. It's what risk they're willing to live with.
So following the question, so like a lot of elder patients who are anticoagulated, and they comes with like suspicions of subarachnoid hemorrhage, but we don't see it. Like, I read it that it cannot earlier subarachnoid is not seen in the CT scan, but there is a delayed hemorrhagic intracranial hemorrhagic, and do you you have any radiographic evidence, and you didn't do LP, and then this patient lives like 40, 50 miles away. Do you admit this patient for follow-up CTs?
So I think, so the question is, do we need to admit the anticoagulated patient who we are concerned for subarachnoid hemorrhage? I don't think necessarily for spontaneous subarachnoid hemorrhage. I think your question is more pervy to the patient who has closed head trauma.
Okay.
Yeah, so I don't know if we're going to take that on. Do people want to go down that route?
See, this is the danger of doing a talk like this. If someone asks a really good question like that, and you're like, no one knows. I've read those terrifying. Huh?
It'll be on the CTA.
That's a great point. So Dr. Gross points out, so we could do a CTA and evaluation for subarachnoid hemorrhage, right?
Get some aneurysm, and then you're stuck. It's like, no.
Exactly. So that's the one caveat. So that's certainly a reasonable approach to go ahead and get the CT angiogram to evaluate for aneurysm. But if you find an aneurysm, does that mean that patient has a ruptured aneurysm? And what are you going to do afterwards, right?
Which shockingly is 5 to 6% of the population.
So yeah, so just point out that's about 5 to 6% of the population, right? So, and what else have you committed that patient to for the rest of their life? Every time they have a headache, when you discover that they have a subarachnoid hemorrhage, an aneurysm.
So that means that in this room, it's possible that 2 people have an asymptomatic aneurysm. I think Jim is at risk for 3 or 4. Just for
Becoming symptomatic.
So I think, Brandon, what you were asking is actually a related question of the fall down, go boom, I'm on Coumadin, and there's some fairly terrifying studies of you don't have a bleed right now. Is there a risk in 24, 72 hours, that kind of range? Is there a read for a risk of delayed bleed? And it's a terrifying question because some of those studies had shockingly high, up to 10% or so of the folks would actually have a delayed bleed, which is terrifying that you could send someone home with a objectively clean CT scan, no blood that we see at all, and then 1 in 10 of them have a neurologic disaster brewing by having a delayed bleed. And so some authors have recommended admitting for 24 hours of observation and a repeat CT scan. My problem with that is that the repeat CT scan in like 24 hours is not perfectly sensitive either. And so unless you were literally going to keep people there for like a week or 2, because some of these bleeds actually happen like 8 or 9 days after the initial event, no one really knows if that was even related to that fall or not. But these folks are super high risk. And so what I do is I don't admit any of them to repeat CT scan, but I do tell them, and I tell family members if at all possible, look, there's a very real chance of a delayed bleed. If something funny happens in the next few days in particular, but really over the next 3 to 6 months, there could be either a slow bleed that's causing a chronic subdural, or it could be a delayed bleed that has a more acute bleed. So if you suddenly start throwing up, you don't feel right, anything like that, you got to come right back because we may need to spin you again. Rich, did you have anything on that before we move?
Real quick, if they're on Plavix, I don't worry about it. All right, it's usually found on the first CT. I use INR. The INR is really high. I tend to maybe keep them and observe them, get a repeat later. And when I say really high, it's arbitrary. 5 greater than 5, INR greater than 5. Much below that, I feel a little more comfortable sending them home with very strict return precautions. All right, I saw like 3 hands.
That's where I was going.
Okay.
I just got a quick question. So just out of curiosity, if the miss rate is 1 in 300 within 6 hours of one, so what's the miss rate after 6 hours?
Oh, so that literature really doesn't touch the delayed bleeders. So if they, for some reason, come in with worst headache of their life for 34 hours, there's not a good literature basis to just do plain CT. That might be a good time for CTA, but the problem is the farther you are from that theoretical bleed, the more likely it's going to be isodense with the other brain tissue, and so you're not going to be able to pick it up. And so that's a much higher risk person. They really need to come in pretty soon after it started.
They're higher risk for missing a diagnosis. They're not higher risk for poor outcomes or need for neurological intervention.
Correct, because they've shown that they were able to live with stable vital signs for about 30 hours, and so it's less likely that they're going to have to get a burr hole tonight.
So it's like a physician-centered risk rather than a patient-centered risk.
We live in a world where people aren't comfortable being discharged and then have blood in their skull. Like they just don't, it's not supposed to be there. Hopefully there's some blood in your skull. But they're not okay missing, it's unfortunately considered a 0% risk or acceptable miss rate, which as we've talked about before is not logically possible. We're going to miss some. And if you're not missing some, then you're probably doing too many CTs and LPs. That miss rate should be very low. It may be on the order of 1 in 1,000 or something like that, but it shouldn't be 0 because you can't possibly do it.
Just a quick question. Reversing the bigger trend on PCC. Anything?
You've grown.
I have a head bleed related question real quick.
Okay, so we're going to postpone your terrible, painful to answer question and go straight to LaShawn.